Hi, my name is Ritesh Bawri. I'm an entrepreneur and also the father of two wonderful children. Interestingly, I'm also someone who's almost died 14 times in my life. From being in a near plane crash to being lost in a jungle, I've seen it all. 7 years ago, I experienced what was hopefully my last near-death experience. I just turned 40. I was diabetic, I was hypertensive, had always suffered from asthma, and I had acidity for at least 20 years. Thanks to the intervention of Professor Ravi Rajan, I was able to reverse all these conditions in 90 days. I was hooked. I had to learn more. Since then, I've read thousands of medical journals and hundreds of books. I've certified myself in physiology from the Harvard Medical School and in nutrition from the Tufts Medical School. I just had to understand what was happening in the human body. I've started breatheagain, a platform dedicated to helping people live a very long and a very healthy life. We've been able to impact thousands of people, reverse lifestyle conditions. You know, the really interesting thing is that even the World Health Organization calls lifestyle diseases potentially reversible. Are we saying that if you just simply made some lifestyle changes, 7 of the top 10 reasons why we're dying could be reversed, or at least the risk could be reduced? To find out more, I put together the riteshbawri show, where we talk to experts and regular people, understand from them what's going on with their lives, and how all of us can live a very long and a very healthy life. Welcome to the show, the Ritesh Bawri Show. I'm exceptionally pleased to welcome my friend, Dr. Nozer Sheriar, to the show. Dr. Sheriar is someone who absolutely worship. He's someone who's given us the gift of 2 wonderful children. Had it not been for him, I can assure you we would not have these 2 children in our lives. He's a very famous gynecologist, someone who's worked with the most famous celebrities in the world, but exceptionally modest, exceptionally calm, and truly a gifted doctor. You really need to hear from him on how to live a very long and a very healthy life. Hello, Dr. Nozer Sheriar. This is truly an honor. If I've not said this before, let me say this on record. As far as we are concerned, you are literally God for us. As parents, we are blessed with 2 children. And if it had not been for you, we had actually reached this point when we had kind of given up. We felt that it was not in our future. It was not in our destiny. It was not in our karma, if you will, to actually have children. Not only did you change that for us, you've managed to give us 2 wonderful children who are literally the center of my life today. So for someone who literally went from not having any to having 2 wonderful children, obviously anyone who's played a central role in that, for me, you are literally God. And I'd like to say this on record. I know I'm not the only person. I know there are thousands of people out there who would echo this sentiment. That's really the role a doctor plays. A good doctor can literally transform your life in many ways. And that's, I think, the journey and conversation I'd like to have with you. How can we sort of find such doctors? How can we sort of work with them? How can we learn from them? And how can we take actions that sort of correct whatever is amiss in our lives, such that the outcomes are truly transformative. Not having a child and having a child is a 0-1 sort of difference. So welcome to the show, the Ritesh Bawri Show. It's truly an honor. We have a lot of ground to cover. But let me start at the beginning. Let's look at fertility itself. Obviously, I'm no expert in this subject, and the idea here is to learn from you. But the little bit I've learned is that women are now starting to menstruate a lot earlier. There are many factors that might sort of play into that. First of all, is this a fact? If it is it the right thing to happen? Is there something we can do to delay this? What's really going on?
So Ritesh, thank you. It's such a privilege being here today. And I can tell you that Dimple and you are both special too.
Thank you.
Ruby and me. The responsibility of looking after not 1 but 2 lives and the family of the woman and her husband is something truly special. I once wrote an article which said, I have the best job in the world, and I totally stand by it.
Thank you for watching. Being connected to each other is easily one of the most powerful emotions a human being can feel. On that note, I have a very small request to make of you. Lots of you watch this channel, but not all of you subscribe to this channel. If you subscribe, you'll get notified of all the new episodes that we're going to be releasing very shortly. We've had some fascinating conversations with some amazing people who have so many powerful lessons to teach. So please do subscribe. If you subscribe to the channel, you will know about all the new episodes we're releasing. So please subscribe now.
Why does this happen? Well, firstly, it happened with improving health. The West is about 20 years ahead of us. And today in urban area, India, we're basically repeating what the West does.
Sure.
And so our girls in urban India, where they are following the same kind of lifestyle, diets, weight gain as the West did, we are seeing menarche earlier. Weight change has made a big difference.
Okay.
And we know that as young girls put on weight, there are certain changes in their hormonal system, menstruations happening earlier. The world we live in, is quite messed up. And there's something known as an EDC, or an endocrine disrupting chemical, where there are certain elements in the environment basically coming as byproducts of the plastic industry and plastics, which play the role of estrogen in the body, estrogen being the female hormone. That's become a reason for menarche happening earlier. So many different reasons. Most of the time, we just need to prepare girls earlier now. We need to have conversations with them maybe a year or two before we did in the past. I must tell you from my personal experience that when I was a part of a Federation of Gynecologists initiative on the girl child, we started going to schools. My daughter was in the 6th. I insisted that we start with the 6th, not because she was in the 6th, because I believed girls in the 6th needed the information. I went to her school, and believe it or not, a few months later, she menstruated. She was better prepared.
Sure. So just to be clear, is this a good thing? Is this a bad thing? Is this a neutral thing?
As I would say, it's a thing.
Okay.
It's a thing that we need to prepare for. We need to give them the information, give them the confidence. But there is also medical interventions when it happens too early.
Okay.
Now, we have two terms I'd like to bring up here. Medical terms, but we'll try and explain them. Precocious puberty and precocious menarche.
Okay.
Puberty is the process. Menarche is the event. Menarche is when she menstruates, but before she menstruates, she will spend almost 2 years before that with certain physical changes. The physical changes could be hair growth in the armpits and the axilla and the pubic area, a growth spurt when she suddenly shoots up and is taller than the other girls in her class, and of course, breast development.
Okay.
Now, if this is happening before the age of 8, I think parents should seek medical advice. If menarche happens before the age of 10, it won't unless she's had those changes. So you can actually prepare for it. Now, you have the option of putting that whole process on a hold medically by the use of medications, allowing her to do 2 more years of growth and then letting her menstruate. Now, there are no medications without implications and side effects. But the benefits would be you've got a child who's now a little more grown up, who's better able to cope with the changes that happen with puberty and menarche. And you also have the benefit of further growth in height, because once she hits menarche, usually her growth stops. And while she's beaten her peers in growth for those 2 years, very soon they'll all grow past her and be much taller. So medical options remain. Whether you take them or don't take them is a personal choice to be made in conjunction with the help of an expert.
Expert, of course. So in a perfect world, would you say that if everything was normal, later is better, like 13, 14 is better?
I would probably put the age, I think 12 is a good
12,
age.
Okay.
12 seems to be a good age, but there'd always be some who do it earlier. The bell curve, others who do it later. But again, we also have to look at the other extreme. If a woman, has not had her changes in her secondary sex characters by the age of 16 or not menstruated by the age of 18, then again, the red flag should go up. And that should be investigated and treated.
Wonderful. No, this is really useful. And also non-medically then, so when you talked about the use of plastics, something I read a lot about, I research a lot about, and I understand how the chemical in the plastic is literally acting like a hormone in the body.
Absolutely.
So would you recommend that maybe especially women are a lot more careful about their exposure to plastic, because it's then diapers, it's then cosmetics?
Absolutely. And it's not just women, the men as well. So you mentioned health, lifestyle. I would basically, again, highlight 2 issues. One is excessive weight gain. And that's really, if there's one thing that's made that whole process come earlier, it's also been the fact that today the girls weigh much more than their counterparts did 25 years ago. You just need to go to a schoolyard to see the big change. When it comes to plastics, these endocrine disruptors, they are there in the environment. I can tell you as a gynecologist, I see 2 major reproductive issues. The fact that menarche is happening earlier is one issue, but 2 other major issues in reproduction. The first is I'm seeing certain birth defects in women in their uterus, which should not happen, which happened when we used a drug called DES, diethylstilbestrol. We stopped using that drug in the 1970s when we knew the problem was there. Then why am I still seeing that abnormal uterus from time to time? I believe it's because of the endocrine disruptors in the environment. The second thing is male infertility has gone up exponentially. When I was a student, WHO took the cutoff for male infertility as 60 million sperms per ml.
Okay.
You know what they've done? They've brought it down to 20 million.
Wow.
So instead of saying, why has 60 million come down
20.
and fixing the world, it's a lot easier fixing the limits of the test. Because if you had 40 million, a majority of men today would fail. Male infertility has gone up dramatically, not just in human beings, but in every species across the world. And that's because we put plastics into every level and environment. So this is something that to a small extent, we can control. Maybe we can't do things with our water supply and what's happening out there, but you can do things in your kitchen and in your home.
Right.
And we find plastics to be so convenient. And I have nothing personally against the plastics industry. But when it comes to the safety of my patients and my family, I would always say, wherever possible, do an audit periodically and try and minimize the use of plastics.
No, absolutely. Like, so even bottles of water, the containers in which you put your food, the containers in which the child is taking their tiffin to school, it's just endless.
It's
I mean, when I started actually looking at it, it was scary. But, you bring up a very interesting point about weight. So as someone who's now spent a decade in the health and wellness industry, weight is a factor that drives everyone. My own personal journey, my goal was to lose 2 kilos of weight. I was told I'm diabetic and I've got high cholesterol and all kinds of things. And I'm like, yeah, okay, sure, whatever. But if I could lose 2 kgs of weight, it was wonderful. So weight does motivate people. And I think that is definitely becoming a bigger problem. But, this whole notion about weight very quickly then starts becoming about body shaming and about, you're judging the person or you're looking at the way the optics are and so on and so forth. But the more I spend time on this, the more I've realized that weight's actually got nothing to do with the optics. It's actually a medical problem. Weight is like temperature. If your body temperature is 104, you would act. If my weight is 20 kilos more than it needs to be, you should act. But yet, we only think about, the optics. So help me understand this a little bit from a doctor's point of view, from a medical point of view. What is the problem with weight?
Yeah, so medical practice is really an evolution. I've often joked with my patients that we doctors practice, and I sometimes wonder why patients haven't asked us, Doctor, when are you planning to perfect? How come you go on practicing?
Correct.
For me, as I practiced, I realized more and more the importance of weight in anything that a doctor does. So in my clinic now, besides the fact that you document weight and height and blood pressure, a body mass index, because you always want something very, very simple
Correct.
to start a conversation with. And it does not have to be shaming at all. When people really understand the significance of something, they will be motivated. And I believe that. So when you calculate something like a body mass index and you tell a person where they are, they automatically see something that they knew in their heart of hearts that they need to do something about. Now, why am I so concerned about weight? Today, the world is suddenly battling the NCDs, the non-communicable diseases. Sure. And many of the NCDs have somewhere in their source the role of weight.
Correct.
Weight can be bad at both extremes. I have a problem today where there is an obsession with not putting on weight and losing weight. And here I'm showing a young girl her body mass index and saying, this is too low, you're underweight. Yeah. And she says, no, but I can't be more than that weight.
Correct.
That's a problem as well. Condition called anorexia nervosa, where women will go to great extremes. And trust me, it's not in their control. It's not something they're doing deliberately. And they affect their whole hypothalamic system. And they have issues with reproduction. But a far more common problem for us today is the fact that more and more percentage of our population tends to have a weight issue and is overweight. And at one point, there used to be a theory of the thrifty gene,
sure,
which was a very important gene for humanity to have when we lived in a world of scarcity. It kept you going. You have a thrifty gene coming into the present times and century when we live in a world of plenty and that gene goes berserk.
Yeah.
And that's where you come up with all your metabolic issues. And those metabolic issues touch so many parts of a person's life. During adolescence, for a young girl, it can cause her problems with menarche. Everyone talks PCO nowadays.
Yeah.
And maybe we can spend a little bit of time on that. As I move a little further ahead, I grapple with fertility issues. Obviously, we're not even talking about the psychological implications and the fact that overweight people are body shamed.
Yeah.
And I'll go to the extent of sometimes saying they even body shame themselves.
Yeah, of course.
Because they've built in their minds a certain picture which they feel they're not living up to.
Yeah.
Going ahead during pregnancy, all the implications of being overweight with all the medical issues that go hand in hand, more hypertension, more diabetes, bigger babies, and then challenges at birth and delivery. Going ahead, we look to what happens afterwards in the midlife and later. And we know for sure that being overweight puts you at a higher risk of certain malignancies,
Sure.
particularly breast. And the new malignancy, which was an old malignancy down the list, and I was just talking about a colleague of mine the other day, carcinoma of the endometrium suddenly seems to have jumped to the top of the list.
Yeah.
And we know that it's linked to obesity, hypertension, diabetes.
Hmm.
And I can't tell you how much it bothers me, because in the last 1 week, I've had 3 patients of mine with this condition, where in the past I might have seen 1 in many months.
Right.
So weight is important. Weight plays an issue. The medical profession has to accept and highlight it. The person you work with has to work with you in a very positive kind of manner with the right tools.
Right.
See, it's all very well to tell someone go lose weight.
Yeah.
But unless you give them practical tools, it's not going to happen. And again, I can tell you the evolution in my practices that I have moved from someone who told women to lose weight to someone who now spends time, motivates them. It's all about motivation.
Correct.
I have with me working 2 dietitians. Every patient of mine goes through the dietitian. In fact, we probably do more diet and less medication.
Wonderful.
And the results are there for me to be really proud of.
Right.
And for the woman to be proud of.
Correct.
While I'm on this topic, I'd like to tell you about what we actually practice in our patients who are overweight in pregnancy. So many years ago, this bothered me. Women putting on 25, 30 kilos in a pregnancy and being told, it's all right, you're pregnant. Women put on weight in pregnancy. Women saying, this is my one chance of doing it, why not? And then it goes hand in hand with all those medical issues. So we started a process of restricting weight gain in pregnancy.
Okay.
The first thing is identification, which means the initial BMI to talk to someone about. The second is the use of a nutritionist who gets in right from the beginning. We now use it for every patient.
Okay.
I have a checklist. There is a tick box. I tell a woman, I will not deliver you unless and until you work with the dietitian.
Makes sense.
Medications. I do use insulin sensitizers. I am a doctor and I know that there are things in medicine I can use. Many overweight women, I do use a small dose of aspirin and motivation.
Okay.
And motivation to walk, exercise, and burn calories.
Sure.
And today you have the tools. Today you have something which can count steps. People will often worry and say, but I don't have time in my life to go to it wherever. So I say, fine, you start counting your steps, put on your device when you wake up in the morning, and let's do an X amount, 8,000, 10,000.
Whatever the number is. Sure.
It's an equation. You disrupt the equation, there's no way you won't see results. We analyzed 46 patients of ours, average weight all over 30 BMI, average starting weight was 88.2 kilos. There were a few 125s and so on. The average weight gain in pregnancy was 2.8 kilos.
So that's just the baby.
The baby weighed more. The baby, the placenta and the amniotic fluid weighed more.
Wonderful.
This woman was on a roll. Believe it or not, this woman who started off the average age of 88, lost 10 kilos easily in the next 3 months and reached a weight she had always dreamt about. It's doable, it's achievable without any significant negatives for the pregnancy. So I think this is where we have to change our mindsets. After all, it was Hippocrates who said, let food be thy medicine and medicine be thy food. And it will pay my patient and obviously by association, me and my practice rich dividends.
So wonderful. I mean, it's so refreshing to hear because, I think weight has just got so demonized. That anyone wanting to lose weight is demonized, anyone who's overweight is demonized, anyone talking about how you should be losing weight is demonized. Because I think this topic has just got hijacked by everybody.
Yeah.
It's got hijacked by the food industry, it's got hijacked by the medical industry and and so on and so forth, and the pharma industry, and everyone's just got involved.
Yeah.
I think it's got hijacked. So there's such a refreshing view of how this is a medical thing that you should be really looking at. This is
and it's also about how it's approached. Okay, it can be approached with condemnation.
Right.
It can be approached with ridicule and it can be approached with support.
Right.
And if they realize that this is, I believe if you can convey to a person what's absolutely in their best interest. And again, I do have a trump card. I've got the fetus.
Right.
When there's a fetus and a pregnancy involved, it's amazing what length women will go to.
Right. To do the right thing.
Incredible.
No, absolutely incredible. I can tell you my own personal journey. So obviously I was overweight. And I think what I learned is, of course, the science matters. And like you said, it is a equation, calorie in whatever you're burning. But I think it's also a little bit about empathy, because what you don't want at that point in time, because you're vulnerable, is to be looked down on. You don't want to be laughed at. You don't want to be mocked. You don't want to be said and told that you're X, Y, Z. I think the fact that you bring such an empathetic point of view to the table, that too coming from a doctor of such renown, I think that clearly would be the transformative practice. So no, wonderful. We've experienced what you've said. I know Dimple only put on about 3 kilos and she lost that very quickly right after. So of course we totally recognize. But if I could just move on to, you talked a lot about the weight and then how it starts to affect the development of the woman. Obviously, one of the major problems that we are now facing is PCOD, PCOS. They say that's the cause of weight gain, but at least the little bit I've read is that's the outcome actually of weight gain. It's the other way around, because you're putting on weight. So your body's storing estrogen, calling for estrogen because you have abdominal fat. And then that's actually creating your PCOD. So could you talk a little bit about that? Like what's going on and what can you do to sort of change that?
At one point, it was described in 1935 by this pair called Stein and Leventhal. It was all about the ovaries.
Right.
We've moved way ahead of that with our understanding. And today we believe PCO, we don't use the term D anymore.
Okay.
It's now PCOS, is a metabolic/endocrine condition. It's in fact more metabolic now than the hormonal. And as you rightly pointed out, Ritesh, it's probably the metabolic changes which are driving the hormonal changes.
Okay.
Now, what happens with PCOS is there is always a weight issue. And a big part of that is because of insulin resistance. Now, incidentally, this happens at about 2/3 of PCOS.
Sure.
1/3 will be a lean PCOS, which is, I always believe, more challenging, because when there's a metabolic issue, it's easier to
at least
deal
you can
with.
Fix that,
It's a little more difficult. There's infertility. There are menstrual disturbances, and there are ovaries which are polycystic. And the moment I have an ultrasound report, the patient panics, or the girl's mother panics and says, my girl has cysts in her ovaries. They are not cysts in the ovaries. It's a misnomer. They are multiple unruptured follicles. It's a spectrum. I have a PCOS at one end of the spectrum who's menstruating, ovulating, and fine. And I would tell her, you're in a good place. Build up on that. Do not allow yourself to gain those next 10 kilos, which will push you to the other end of the spectrum.
Sure.
And the other end of the spectrum, no periods, irregular periods, major cosmetic issues with acne, facial hair, hirsutism, which is basically hormonal midline hair, and other issues. I mean, infertility, of course. You don't ovulate. How do you conceive? And later life metabolic issues. You are now going to, because of the metabolic issues, prone to the metabolic syndrome. Now, just imagine, you're early in your life, you're a young girl, you've actually been told where you're headed. You can make a course correction and prevent yourself from getting there.
Right.
And then there's other stuff like we mentioned, cancer of the endometrium. Too much estrogen, unopposed estrogen is going to lead to cancer of the endometrium being a little more common in later life.
Sure.
So that's where we are with PCOS. It's a condition which needs to be identified. Sometimes you need to do absolutely nothing. I don't think we should be in a haste of labeling people with PCOS, because we need to break it down to where she is as an individual and treat her as an individual. So if I have a girl with menstrual disturbance, I just need to fix that, maybe by giving her progesterone to balance off her estrogens. Estrogen, the female hormone, normally needs to be balanced off with progesterone, which comes in the second half of the menstrual cycle.
Okay.
Or comes in a big way during pregnancy. And maybe we can touch upon that a little later. If she needs contraception and birth control, I'd probably put her onto the pill. One of the most misunderstood medications in human history. Also one of the most widely used medications in human history. And today when I talk about the pill, I have to also talk about the benefits. It deals with PCOS, less ovarian cysts, cosmetic benefits, and interestingly, less ovarian cancer.
Okay.
So that balances off. If she wants fertility, I've got medications to deal with that. And then, of course, later on in life, I need to be extremely vigilant to prevent those metabolic issues and tell her, check your weight, make sure your insulin resistance is dealt with, and you are less likely to have type 2 diabetes when you reach later in life.
Sure.
What women have lost, and I have no problem with that, what women have lost in the last 1 or 2 generations, and it's interesting when you speak to the older generation, they were all 8 and 9 brothers and sisters.
Correct.
So when a woman asks, but doctor, why did this happen to me? Why did I have fibroids? Why did I have endometriosis or adenomyosis? I jokingly respond, because you didn't have 8 or 9 kids.
Correct.
I'm not asking anyone to have that, but I'm saying medicine has to now recalibrate to help her with what she's lost out. A century ago, a woman menstruated 40 times in a lifetime. Today, women are menstruating 400 times in their lifetime.
Right.
And this unopposed estrogen going on year after year after year is creating a lot of our medical issues. So I think now is the time when we need to have this kind of conversation ourselves as a profession and as society as to what can I do for a woman who says, I'm done with, who says, firstly, I'll start my family late.
Right.
Or says, I'm going to be done with my family after 1 or 2, where I will use contraception to give her the protection her pregnancies would have.
Right.
And to an extent, it probably is going to make her much healthier in the long run with her other issues.
So there were actually lots of things that you said in what you just said. And if I could parse and pick on 2 or 3. So first is, in your opinion, then what is the right age for a woman to actually start considering? 1, 2, let's say whatever that age is, and you will answer that question. How many years in advance should she then start preparing? So I understand that, you need to fix many things, maybe your metabolism, weight, et cetera, et cetera, et cetera. What's the minimum? Let's say, okay, if I started 3 years, 5 years, 2 years before, at least by the time I got to fertility and I got to actually conceiving, I was kind of ready. What's that sort of?
We are having this discussion in our profession as to when should women go ahead with their pregnancies. And the conversation is, women should do it early because difficulties happen later. I disagree. I believe pregnancy should happen when she wants them and not when she has to have them. Will it get difficult? Of course it will get difficult, but we have to help her out with that. If she leads a good, healthy lifestyle, she probably keeps herself going. And today I have a number of late 30s and even over 40 pregnancies in women who've kept themselves really, really well. Your fertility is highest when you're around 25, starts going down and significantly goes down after 35. And this is something we have to recognize. I told you earlier about the birth control pill, and I believe the birth control pill in the long term has beneficial effects, but there are other contraceptives as well, not just the birth control pill, which the woman should consider if she's planning to postpone fertility, because I also believe that she's the one who gets to decide when the pregnancy happens. There are ways today to try and identify her fertility status and slot her where she's going to be. For me, her mother's history is extremely important. And when I have women coming to me in their late 30s and 40s, my first question to them is, when did your mother menopause? Makes a big difference. But suppose I still was to give her a better idea, and you've got lots of women today, and I'm talking about the 2 Indias, urban India and the rest of India, where women are achievers, they're professionals, they've spent years and years studying, and they would sacrifice a lot if they had that first child. So I completely support the fact that she will decide when she wants to go for it. But she should do this with the right information.
Sure.
There's one test which I do a lot more commonly nowadays. It's a test called AMH. It's the anti-Mullerian hormone. And it's a test which kind of tells you about the ovarian reserve.
Okay.
And if a woman has a good AMH, she probably is okay if she wants to delay a little bit. But if the AMH is going low, she should know that when she's making this personal choice of waiting.
Okay.
Because then she's better informed. This is coupled with a few other things. There's something called as an antral follicle count, which you do on the 2nd or 3rd day of your menstrual cycle by ultrasound. But for me, an AMH usually suffices. If she's older, I would do an FSH and an E2, FSH being the hormone from the pituitary controlling the ovaries, and the levels will start moving up as you move up in midlife, telling you that now you're on borrowed time.
Correct.
What happens when a woman really wants to delay fertility? 1, because nobody in her life she wants to share a pregnancy with, or 2, she's got certain career goals she wants to achieve. For me, 32 is around the age when I at least start conversing with them about the possibility of freezing their oocytes if they are single or the embryos if they are married.
Okay.
And I believe that lets them off with this difficult decision, and she can then delay it for whatever time she wants. Once technology has frozen those oocytes or embryos, the pressure is off completely. And maybe she might do the first pregnancy or on her own. She still has those available to her for a second pregnancy. And I think women should now start hearing about this or asking about this once they get into their 30s if there is no pregnancy plan in sight. One final thing I want to say about AMH is because AMH is getting very misunderstood nowadays.
Okay.
The moment the AMH goes low, everyone's talking about interference, about IVF, about donor eggs. A lot of my patients who've conceived with a low AMH, and if I was to give them an analogy, I would say it's like the fuel gauge in your car. You're hitting your reserve. Your car won't stop functioning, but it's time to find a gas station.
Right.
And that's how you need to interpret your AMH.
Wonderful. Wonderful. If I could then just quickly move on. Obviously, medical science has evolved a lot in the last 100 years. The whole pharma industry, the medical industry has evolved a lot. Again, we've seen the benefits. So a delay in pregnancy, for example, to allow the child to be born later than earlier, et cetera, et cetera. Could you just talk me through maybe the highlights of what's happened in the medical world that's aiding someone like you to do what you want to do and yet manage all the complexities of childbirth?
So the highlights would be, one is a much better understanding.
Okay.
And we haven't, like in physics, we haven't found the unification theory as yet.
Okay.
But we are understanding things much better. We are understanding PCOS, human fertility, much better than we used to.
Okay.
We have a lot of choices. And let's start off with the fact that deciding when to have the pregnancy. I've got amazing choices today that I can give the woman and let her choose from when it comes to delaying a pregnancy, something that suits her personality, her needs, and her medical history as well. For me, terminating a pregnancy today, if she doesn't want a pregnancy, has moved to next level, where I've got medication abortions, and a majority of abortions in the world today are medication abortions. We've simplified that.
Okay.
When it comes to conception, today we have really achieved a lot when it comes to infertility management. The last milestone that we haven't achieved is convincing the uterus to retain the pregnancy.
Sure.
IVF has become brilliant at ovulation, brilliant at fertilization, brilliant at creating embryos. We still haven't cracked that signal by which we can tell the uterus, please retain this pregnancy we are putting in. Maybe someday soon we will. When it comes to managing high-risk pregnancies, there are a number of tests which didn't exist 10 years ago. I mean, there's something called as a thrombophilia. A thrombophilia are certain anticoagulants in our system which are deficient. Now, when those were deficient, I had patients of mine with multiple stillbirths. Thanks to the fact that I have the test today, I can put them on blood thinners and give them a successful outcome of pregnancy. Monitoring a pregnancy. Ultrasound has left almost nothing hidden.
Right.
Today, the pictures you get in the first trimester, you pick up blood flow abnormalities, you pick up almost every congenital defect. It's an advanced, simple test called an NIPT, which you do at 12 weeks. You pick the baby's DNA from the mother's blood. No more amniocentesis. You take a maternal blood sample, you isolate the cell-free DNA, test that and find out the baby's genetics. Delivering. Today, I have the backup of having neonatal care where I can deliver babies really early if they need to be delivered,
Correct.
which I would have lost. And I have sent home babies weighing 550 grams. I have sent home babies of 24 and 25 weeks because I now have the people backing me up who have the skills and the technology to look for those babies. When it comes to surgery, the great advances have been minimally invasive surgery. It's amazing that today we can do great stuff. Maybe send the patient home the same day. Hysteroscopy is something you do inside the uterus. Laparoscopy is outside the uterus. And then finally coming on to the later part of life, women are going to spend a big chunk of their life at or after menopause.
Sure.
And today we also have the understanding and the technology. Today we also have the holistic approach of lifestyle, medicine, and food to get them through this very difficult phase, which otherwise women grappled with and struggled.
Sure.
So there have been changes in every aspect of what we do. They keep happening and they're always very exciting. But the important thing is the change should not be there for the sake of change. It has to be there because we give something better to the women we look after.
Oh, absolutely. And not to mention the joy, the absolute sheer joy of being able to see a child inside the womb. My God, it is.
So I love getting up in the middle of the night and going and delivering a baby. I love being in that room when that joyfulness happens. I love being a part of that child's life growing up. It's something you just can't describe.
Incredible.
You can't.
Incredible.
And that's not going to change. I often joke with my colleagues doing robotic surgeries. Robots are going to do a lot. Robots are never going to deliver a baby.
Sure. Oh, wonderful. If I could ask you a quick question about the pregnancy itself. So one of the very common things that are now beginning to happen is gestational diabetes.
Yes.
What is this? Like, what is happening? And what can you do?
Firstly, as the human race has changed, diabetes has become a big problem worldwide. You know that, which is why NCDs is something the WHO is talking about. International Federation of Gynecologists has suddenly got a separate committee for NCDs. We are doing the same thing at national level. And among the NCDs, the top two that we are most bothered about are hypertension and diabetes,
sure.
Both of which are a problem in pregnancy. One is women going into pregnancy hypertensive or diabetic, or larger chunk of women who become hypertensive during pregnancy, preeclampsia, or diabetic during pregnancy, gestational diabetes. Now, this is something, again, that we need to take care of very closely because the implications can be quite dramatic.
Okay.
In case of hypertension for the mother and the child, for the mother, it could even be life-threatening. You could have convulsions, eclampsia, you could have a stroke, you could even have death. And for the fetus, you could have growth restriction and stillbirth. For diabetes, you have the problems of, if you've got uncontrolled diabetes going into pregnancy, a very important cause of birth defects.
Sure. Okay.
Totally preventable. If you had picked her up preconceptionally and normalized it, and she went into pregnancy well controlled, she wouldn't have that problem. The second problem with diabetics is depending upon the type of diabetes there is. Type 1, long-standing problems with blood supply to the fetus. Very close monitoring, deliver early when you feel time is right. But for a majority, it's either type 2 or gestational diabetes. It usually comes in the latter part of pregnancy. That's when you need to monitor and identify. Your management starts much before with prevention, where you have a good control over weight gain, a good, kind of a diet that is encouraged through pregnancy, balance it with an exercise schedule. And I truly believe that we can reduce the incidence of gestational diabetes that we are seeing today.
So, sorry, which was the question I was sort of in my head. So are you saying that it's an option?
I am saying that if a woman is good to start with in her pregnancy, whatever her family history be, you can definitely modulate the happening of gestational diabetes.
That's incredible.
In pregnancy.
That is incredible. Like I actually believe there was just one of those things that happened and you had very little choice.
No. So basically with gestation, okay, let me put it this way, Ritesh. You were type 2 diabetic. Correct. And you reversed it.
Yes.
Gestational diabetes very often behaves like type 2 diabetes in pregnancy.
I see. I didn't know this.
Why don't we just step in a little earlier?
Right.
We give her the right kind. And I can tell you with that change I told you about my patients in my practice, I do seem to have brought down the incidence of these overweight women. I'm talking about a woman who's 125 who finishes pregnancy at 124, or a woman who's 121 who finishes a pregnancy at 110. It has to give you some metabolic advantage and benefit. We also have medications, which we are today using more and more. Aspirin has been used a lot. Of course, the jury is still out in every possible condition, but we know that low-dose aspirin plays a role, and we now do a test at 12 weeks to find out you've got a higher risk of preeclampsia or not. And bringing in aspirin at that time will lower your risk or at least modulate the disease. Similarly, with gestational diabetes, if I can get her diet and exercise right, I can hopefully prevent it or at least modulate it and make it much less. Now, I identify it usually in the late second or early third trimester, which means vigilance, which means doing the right testing. Glucose metabolism in pregnancy is very misunderstood. A woman who's pregnant does not behave like she did before she was pregnant because she's got a fetus within her. And that's something that we have to change and use to our advantage, this understanding. Medications, yes. Today we are using metformin-like substances. Sure. And what we weren't using 20 years ago when we were told you couldn't use them in pregnancy. We're using them all the time. And whenever necessary, the use of insulin for those patients in late pregnancy. If I can prevent macrosomia, if I can keep a pregnancy long enough, if I can keep the blood sugars under reasonable control with the help, it has to be multi-specialty. It has to be nutritionist. It has to be exercise. It has to be endocrinologist. Today, my outcomes with gestational diabetes should be no different than my outcomes with a normal patient. And I'm telling you this as a person who's had a series of people in my family in the past, before I really came into OB/GYN, who had lost late pregnancies to gestational diabetes.
My God. This is absolutely incredible. Like, even I've been doing this 10 years. Somehow I always had this notion that there was hormonal flux. And that was what was triggering.
The hormone flux was always there.
Right. That's so correct.
Why is it that the gestational diabetes incidence is going up so dramatically?
Exactly.
The hormonal changes of pregnancy haven't changed, but women have.
Correct. No, wonderful. Okay. If I could move on, natural versus cesarean. There's always a tussle. And I think increasingly you're finding more and more people are just opting for, or being asked to opt for cesarean childbirth. Could you just walk us through the differences, and under what circumstances would you choose one or the other?
Right. So basically, I would classify it as a vaginal birth or an abdominal birth.
Right.
We get very uncomfortable with some terms, and the medical profession is saying, they don't like the term natural or normal. So fine, I'm okay with vaginal. Vaginal birth was how it was meant to be. When evolution spent hundreds of thousands of years doing something for us with benefit, it has to be the default setting.
Okay.
And I can tell you the benefits of delivering a baby vaginally for the mother, for the way she gets back to normal afterwards. They have to be seen to be believed. And I think women know that. I've always believed that women would prefer vaginal births. What changed was the fact that society has also changed. Sometimes cesareans are done maybe because the doctor feels safer and he wants to take what he thinks is going to be less risky because he's being judged and monitored. And you know what the medical legal environment is.
Correct.
Of course, there's always going to be talk about the benefit to the hospital or to the system by doing cesareans. And that is something you can do away with very easily. And personally, in my practice, I've always treated both the same. I don't believe a hospital or a doctor should be benefiting from one or the other.
Sure.
It has to be the same.
Sure.
So that could be changing it. We lose our plot with the first delivery. That first cesarean has to be avoided wherever possible. Because once she's had a cesarean, the chances of having a cesarean the next time around are dramatically increased.
I see.
I know a lot of us now believe that women want more cesareans. I don't think that's true. I know that in my practice, I would respect a woman who makes a choice of having a cesarean, and I would have lots and lots of conversations and discussions with her, but at the end of it, I would respect her. But I believe that would not even be 2.5% of all cesareans. So it's a myth that women want cesareans. There will be more cesareans. I'm not saying you can put that back into the box. And most of those, if I'm dealing with a very, very small baby, I will do a cesarean.
You can't choose. Yeah.
If I'm dealing with a baby which is a malpresentation and not in the right position, I would do a cesarean. If I'm dealing with a placenta in the way, I would do a cesarean. Where I would not do a cesarean automatically is if she's over 40 years. Why can't she deliver normally?
Right.
If she's had an IVF, why can't she have a cesarean normally? If she's got a loop of cord round the neck, every third baby I deliver is a loop of cord round the neck. So those are not really options. There is a person by the name of Robson, a very interesting person from Ireland. And Robson has come up with criteria, which the WHO is encouraging. And I know we read newspapers and sometimes, these days we have become very mistrustful of professions.
Yeah.
And some years ago, it was 15%. If you're more than 15%, it's wrong. WHO says 15%. That's not true at all.
Okay.
India is 17% as a country. All right. So as a country, we aren't doing badly. Where we are doing terribly is the fact that we are doing too few cesareans in some areas and too many in others.
Correct.
Too few in the public sector and too many in private sector. That's what we need to look at. Robson's came up with 10 criteria, of which the first 4 groups were women having their first pregnancies, women who are being induced in their first pregnancies, women having their second pregnancies, women being induced in their second pregnancies. I believe hospitals should be judged on these 4. These 4 rates should not be high. These 4 rates have to be a reasonable 10, 15, 20, 25%. You cannot have a 50% in these rates.
Right.
And that way we'd have a perfect balance. And I think now it's time for patients also to start asking hospitals or doctors, what's your Robson's 1 to 4 cesarean section rate?
Interesting.
And that would give you
which in a way, sorry, I'm interrupting, but which in a way kind of addressed the question I wanted to ask. Like you said that women mostly not want a natural, but then how would I exercise that choice? I'm confronted with a doctor who knows 100x more than I do.
So, it's very interesting. It's also cultural. Part of it also comes from the medical profession there. South America has gone big on cesarean sections.
Okay.
Now, one thing that does happen in natural childbirth is the pelvic floor gets stretched. There is a higher incidence of incontinence, and women, they make a choice saying, we don't want our pelvic floor to be affected. We'd rather go the abdominal route.
Sure.
But those are some cultural places, some cultural issues. In most cases, the cesarean section rates are higher because of how medicine is practiced.
I see.
And I think we need to probably have step back on the medical front, give women the right information, do the other stuff. You're worried about the pelvic floor. Let's give you the best vaginal birth. Let's do the post-delivery care and exercise that you're supposed to do, and you can address most of those things. No, I don't believe that a majority of women favor a C-section.
Wonderful, wonderful. If I can then quickly move on. So let's say the birth has happened. There's obviously a long process after, right? It's about losing the weight. It's about the production of milk, lactation, for example. Again, you start to see lots of challenges, right? So losing that weight becomes close to impossible for a lot of people. I hear cases of people lactating for 1 to 3 months at best, and then very quickly that lactation stops or at least drops very significantly. What are your thoughts on that? What are the best practices? What should a woman be thinking about? What should she be actually doing to make sure that post-pregnancy, both mother and child are actually okay, doing the right things? And what are those right things?
So if I had to group them into 3 areas, my first would be her support.
Okay.
All kinds of support, whether it be lactation support from the family. You have to create that system. The second has to be nutrition, and the third has to be exercise. I believe the first 3 months after delivery are the privileged 3 months. And we somewhere miss out the benefit of the first 3 months, particularly in our country where culturally those 3 months are the ones where we are absolutely at our worst.
Yeah.
Women put on weight in pregnancy for one purpose and one purpose only, and that is to lactate.
Sure.
She's already got her weight. She's already got her stores. Let her use those stores to lactate. She's going to get back to normal. If the entire animal kingdom can do it, we can.
Correct.
Put the baby onto the breast as soon as possible. The earlier, the better. It's amazing when you put a baby onto the breast. Within the first half an hour, 1 hour, the baby just starts doing it like it's always been doing it. The more you delay, the more you separate the baby from the mother, the more difficult it becomes. I believe today lactation support has become more specialized. There has to be a group of people who have to be there for her, and they have to be people with the professional training and background to give her that confidence and support. And then you bring everyone else in. So lactation, lactation, lactation. Having said that, let lactation not become a cause for distress for women.
Okay.
And somewhere I see the woman herself and people around her put too much pressure on her. She is not a machine. At some point, she is going to hit break point. And I do sometimes have issues with my pediatricians where the woman is expected to do nothing else. Now, she is a human being with her own needs. And at some point in time, she's also a modern woman, and it's going to start getting to her.
Correct.
And then you got the postpartum blues and the depression, which are inevitable. So we always have to find middle road. And I always say no bottle, at least not initially. I always ask my patients to start taking the benefit of a breast pump. It's her milk and her milk alone, which is going to the baby without her having to sit up 24 hours a day. Why not? She has a life. She should be stepping out. That's ridiculous. 40 days in the house has to go. They are encouraged to get out of the house as soon as possible for that 1 hour. I always say it's that 1 hour off for good behavior, and they can come and live with the next 23 hours.
Correct.
And the panic doesn't step in. We have to deal with families, and we have to deal with them very cleverly. Mothers, mothers-in-law, and the entire extended family, and have them on your side.
Right.
And we develop strategies to do it. So I always will appeal to their vanity and tell them, but doc, we've always eaten this, okay? Yeah, but the rest of the world doesn't. How come? No, but we've always eaten this. Then I have to say, but look at the life you had. Look at how hard you worked. The girls today don't do it. And that kind of
Calms him down.
strikes home and says, "You're right. So she can't do laddus. You could. You were physically very fit." And so anyway, that's one. Food. She does not need change her diet in a big way post-delivery. And that's again where the nutritionist comes in. And you just keep her going and keep her going well. She needs good nutrition. She has to replace everything she has used, but at the same time, she shouldn't have to overdo it. In fact, I've often found quite the opposite. Giving a diet to a woman which she's never been used to is definitely going to cause her indigestion and other problems.
Of course. Yeah.
And finally, physical activity. Women have to start exercising as soon as possible, whether it's a normal or a C-section. I would encourage exercises within the week. They have to start walking as soon as possible. They can start doing the light weights and stuff as soon as possible. I give them 6 weeks to start getting back to their normal life and normal activity. And if you do all these things, you also keep her emotionally, and you have to watch for signs.
Right.
We've been in denial of mental health for too long as a profession everywhere in the world, but particularly in our country.
Sure.
And we have to look for signs, and we have to step up immediately if you find that this patient could be going in for the blues or for a depression.
Sure. I definitely want to come back to this topic of depression, the postpartum depression. But if you permit, so in your opinion, then how long should the mother then be trying to
breastfeed?
Yeah.
As long as she wants to and as long as she can. Most of my patients would breastfeed for maybe a year.
Okay.
Or some of them longer. Pediatricians would have them do it longer. But the reality, Ritesh, is that we are living in a world where expectations of women are very different. She's a professional. She's going to work. She gets now, thankfully, leave for 6 months. But in the past, it was barely 3 months.
Right.
I know my wife went back to work on the 91st day after having given birth in those times.
Sure.
Where is the support that the system gives? Very few companies are really enlightened enough to give women that support at workplace.
Right.
Only recently have they started rooms for pumping their milk.
Right.
Only recently have they started offering refrigerators to store the milk, or a creche for the child.
Right.
And we want women in our workforce because they are the amazing half of the workforce,
course,
which
absolutely.
we can't do without. So part of it is not for the want, part of it is for the need. They want to feed more, but unfortunately they can't because they need the job and they are not allowed to feed more.
So if I could just pick up from the conversation we've just had and talk a little bit more about this postpartum depression. What exactly is it? Why is it happening? Is it hormonal? Is it chemical? Is this a natural thing to happen? How should you recognize the symptoms, and then how should you deal with it?
So there are many times in a woman's life when she is vulnerable to mood changes and mental health issues. Coincidentally, many of these coincide when there are dramatic hormonal changes. So we always say for women, there are 4 wake-up calls. They get this sign that the next one is going to show up and the next one is going to show up. And you got to read these signs. The first is a PMS, premenstrual syndrome. Also happens to be the time in the menstrual cycle when the estrogen and progesterone levels fall dramatically before she starts menstruating. The second is postpartum blues and depression, blues being the milder form, depression being a clinical full-blown depression. When again, the hormones of pregnancy, primarily progesterone, but also estrogen, tend to fall after the birth of the baby. The third is something not common in our country, but yes, in some parts of the country, it's called seasonal affective disorder. Again, something quite interesting. It is very often related to the length of the day, a shorter day, less sunlight. Some seasons tend to cause more depression. And then finally is what happens with menopause. At this point in time, she's particularly vulnerable because on one hand, her hormones have crashed, making her more vulnerable. On the second, there is this baby who you love but is demanding, and you suddenly have feelings of inadequacy. It's not what you pictured in your mind. You thought it was going to be something that was a cakewalk and a breeze, and it's not. And the third tends to come from the support and the cultural taboos and bans that we put on women. So I think it's a bit of all of these. But when it is a depression, it has to be treated like a clinical depression would. Postpartum blues can be salvaged. They can be salvaged by reasonable talking, confidence building, counseling. But when it comes to an actual clinical depression, I believe this is when the mental health professional, it has to be identified early. There are these scores. There's a DAS score, which you have a checklist which a woman can be asked to fill, which helps you differentiate an anxiety from a depression. Sometimes it's just plain anxiety. It's feeling that you just might not be up to the role of motherhood. And when it comes to depression, there has to be the involvement of psychiatrist, psychologist, and even medical treatment whenever required. I mean, in extreme cases, you could have a disaster if this is not addressed and looked after. But to start at the very beginning, I think a majority of these cases can be prevented. And I did briefly mention this when we had an earlier question. And you just got to, it has to be about her. She has to be made to be feeling good about herself. She has to be reassured all the time. The people around her have to give her the best possible support. They have to be her support system. I always tell my patient, you do what you're supposed to do. It takes a village to raise a child. Let the village do its own work. Ask for help. Women often wait for someone to offer help. Here are people around her who are being so sensitive to her feelings and feeling bad to offer help. And that's where the mess comes in. So I said, you demand help.
Right.
You need sleep. You need rest. You need a break. You need to spend some quality time feeling special with your husband.
Correct.
Which is why I always feel that I first bust that 40-day myth and make sure that my patient gets to go out, go for a drive, go for a coffee, go for a dinner, do things she likes. And most of the time you can get through this difficult phase.
So I'm completely in shock, actually. So what you're telling me is that a lot of this, barring maybe the very extreme cases, is circumstantial, not medical.
Hormonal.
But
leading
also
to circumstantial.
Yes.
And in some cases, in the very vulnerable, then you can have all the problems of clinical depression and you need medical treatment to salvage those. But a majority of times, you have a woman who's sitting there on the edge in whom she's just not feeling good about herself. She is going to feel low, break in, crying spells very, very easily. Those are the ones which you have to identify, handle with sensitivity, and identify the ones who are going beyond that to what you just mentioned, the absolute clinical depression. I mean, historically, let's face it, this is again something that we are seeing more and more nowadays. We are putting so much pressure on women, and women are putting so much pressure on themselves. And it's not just from the family, it's society and other social media.
Correct.
And social media can be supportive and social media can be very, very judgmental and disruptive.
Right.
So I've always felt that the role of the caregiver, the role of the family at this point in time, unconditional support, give her everything that she needs. And yes, you can definitely make a difference.
No, so which is why I'm sorry, I'm again sort of re-emphasizing my question, which is that you are saying that in the cases where it's not, sort of clinical depression, if the woman had a stronger support system, had a more sort of supportive environment, had people more sort of understanding of what she was going through, provided that, sort of fostering care and concern, then she could be better. And
Absolutely.
then the hormones are not driving the outcomes alone.
Hormones make her vulnerable, but we can pull her back from that vulnerability.
That's incredible. That's not something I knew.
Again, let me just take you back to nature. Let me take you back to how humanity had its childbirth for tens of thousands of years. Yeah. Let me take you to the support systems women had in the past.
Yeah.
Very much like a herd of elephants where there was an elderly matriarch who kind of sees you through difficult times.
Correct.
And women did it. And somewhere along the way in the West, they lost that support with nuclear families. They're pretty much on their own in our country as well. And then there's always cultural things which, rather than helping, are putting more pressure on them.
Correct, exactly.
I think if we can deal with these and address it, and that's where there has to be the role of everyone. My role for her is to be there, to not just be her doctor, but to be her everything. I always say, even a co-conspirator, to sometimes make sure that you keep everyone in line. And a majority of women will take this in everyone goes through hormonal changes.
Correct.
Everyone goes through disruption.
Correct.
And yet some don't do it well and others do it better.
Correct. No, I mean, you're obviously everything for any mother who's expecting a child.
I mean, the first thing I tell them is the world works on the philosophy of the fact that a mother can do no wrong.
Right.
I mean, who has the best interest of the child?
Correct.
Every woman is genetically programmed to be doing what she has done. What have we done? We've overridden the instinct and the genetics and the internal information with a lot of external judgment, a lot of external routines, a lot of external pressures, and made her unsure. She suddenly starts doubting everything that she knows she should do.
Right.
And that's probably where we need to do a rethink. We need to be there, giving her that unconditional space and support. And in a majority of cases, I can tell you that it would work.
They'll be fine.
But you also have to identify the ones in which it doesn't work.
Sure. No, of course.
And then be willing. Again, there's so much hesitancy to seek medical help for mental illness for anyone, anywhere in the world, but more so in our country. And one of the best allies I have is my dear friend, the psychiatrist, and the counselors that I use. And I would say that they are just wonderful for not just this, but so many medical issues my patients deal with.
Incredible. No, this is so empowering actually, because I know for sure, I thought it. I know at least the few people I meet seem to tend to believe that this is just a natural outcome and there's very little I can do.
So that's, in a way, that's letting yourself off the hook when you're the family and the people around her.
Yeah.
And yes, and there's also then a tendency of medicating too easily.
Correct.
I mean, we are as a society also today using anti-anxiolytics and antidepressants in some situations very casually. And I think a majority of cases don't.
Correct. No, wonderful. If I could just move on, then, obviously I've read your book and we will certainly spend some time talking about it. But I had not heard this term perimenopause. What exactly is perimenopause? What is happening and how should you look for the signs and what should you do?
So we spoke about menarche earlier.
Correct.
And the other end of reproductive life ends with menopause, which is an event.
Okay.
A menopause is the event when the woman has a last menstrual cycle.
Okay.
A year after that, if she's not menstruated, we say she's menopausal.
Okay.
Like adolescence, the climacteric is the transition. So there is the premenopause, which is the 4 to 6 years before the event. And there's the postmenopause, which is the 2 to 4 years after the event.
Okay.
It's important to see this whole period, in its entirety, because many of the symptoms that we read with menopause start happening years before she reaches menopause. So here's a woman who says, I'm menstruating regularly, then why am I getting hot flushes?
Right.
I'm menstruating regularly, why do I have these mood changes or my vaginal dryness? Because that's when your hormones start fluctuating all over the place.
Okay.
So when we did this book, the idea came with menopause, and I said, but that's too restrictive.
Right.
Let's address the needs of women before, during, after, and even thereafter.
Sure.
Which is why we didn't stop at perimenopause, we said and beyond. I was having difficulty in communicating this concept. So what I did was I came up with an analogy, which now people understand very well. 24 hours of a woman's life. Menopause is the time the sun sets.
Okay.
You know when the sun is going to set. You have a time. The amazing colors before sunset that the sky has, orange, yellow, pink, that's for me the premenopause. And the twilight after the sunset is the postmenopause.
Sure.
And the beyond is the rest of the night.
Okay.
So perimenopause is the time when you start off with the changes leading up to menopause. Menopause is the time when you stop menstruating, or in some cases, she may not be menstruating because she doesn't have a uterus, but when hormones will tell you that this is it, the ovaries have packed up their function.
Okay.
And the immediate postmenopause is the time when her symptoms will be the most dramatic.
Okay.
After which she settles into the rest of her life.
Okay.
So that's for me is perimenopause, which is what led to the book being called Perimenopause.
Sure. What are the signs that you're looking for then?
So basically, I would say 4 or 5 signs, starting in perimenopause, going up to menopause. The first is menstrual disturbance. So there can be many different changes. Periods can start getting shorter. Periods could start getting longer. They could start getting irregular. But there would be some menstrual change. Her ovaries are now functioning a little differently. The second is mood changes. With the hormonal fluctuations, and we spoke about them before, there would be moods ranging from anxiety to sadness and depression to anger. A lot of women at this age suddenly, and we can talk about that later. I feel, again, like I spoke about earlier, it's not just the hormones, but it's also the life situation she's in that leads to that. The third would be, if I was to give one kind of adjective for menopause, I would say dryness.
Okay.
Whether it's a skin, a hair, so cosmetic changes, whether it's the vagina and vaginal dryness and all the implications of that, including painful sex, dryness is an issue.
Okay.
So these are the kind of changes that you start seeing. The most dramatic change which people associate with menopause are hot flushes.
Sure.
Probably the least important medically, but the most dramatic for that woman.
Correct.
In what she feels.
Yeah.
And vasomotor changes, which are hot flushes, it's called the VSM, the vasomotor syndrome. In that, you have these sudden changes in the way the blood supply to the skin dilates and constricts, and that can be very disruptive.
Okay.
And that sometimes starts a few years before menopause, goes on for a few years after menopause. In a majority of women, be 2 or 3 years, maybe 4, and for some women, even longer.
Okay. And so then are there things you can do? Is there like a lifestyle intervention? Is there medical intervention? Is there something you can make it easier? I know hot flushes is something even we sort of hear about.
Yeah.
At least to the limited extent of my knowledge, there really isn't any specific cure. But maybe you would know better. Is there actually a cure?
Hormone therapy.
Is that...
Hormone replacement therapy for hot flushes is magical.
Okay.
I sometimes joke, my patients think I'm a magician, but I'm not.
Okay.
It's the medication. So that's one. If there's an indication for menopause hormone therapy, hot flushes are right up there.
Okay.
There are things you can do. My co-author Shonali often talks about how each decade decides how your next decade is going to be.
Of course.
So if you're looking at your 40s, you better start working on it in your 30s.
Okay.
We spoke about the major symptoms, but there are other issues such as cardiovascular health and bone health and other endocrinopathies, which you can actually change, modulate if you start working on them early.
Right.
When it comes to the symptoms I described, for example, the menstrual symptoms, you can deal with them, but for that, you usually need to go the medical way. Initially, you could just reassure. I tell my patients that having a period which is short or long is not an issue unless it's bothering you. And then here again, there is a role for contraception.
Okay.
People forget that women still need protection till the day they reach menopause. I often have unexpected pregnancies for women in their mid-40s because they thought it can't happen to me.
Sure.
Don't ever be careless till the day you are confirmed menopausal for at least a year.
Right.
You could still get pregnant. From the other symptoms, as far as the mood is concerned, I think this is when we probably need to start working with them. I don't know, sometimes non-hormonal medications and supplements, something like evening primrose oil.
Correct.
Which has worked for PMS, which seems to work quite well here for those symptoms without having to really medicate them, works. We could probably have a conversation on phytoestrogens, which is again a plant-based estrogen-like substance, which has none of the risks of hormone therapy.
Soy, for example.
Which is soy, tofu,
exactly.
edamame, all those kind of stuff. So that definitely plays a role. Exercise plays a very, very important role.
Okay.
In the feeling of well-being and in how she gets into menopause and approaches menopause. And then for women who require it, there is no doubt that today menopause hormone therapy on a case-by-case basis has a very important role to play in individually managing menopause. Women do not have to suffer symptoms anymore. Women do not have to force themselves to go through something and then have someone tell them, you know what, it's going to be 3 or 4 years. Live through it. No, you don't have to live through it. You can have quality of life, and medicine is there to help you. Controversies have always been there. I know everyone always thinks back to the WHI study in the 1990s, which was completely misinterpreted, not done. That particular section wasn't a proper section. And I can tell you for sure that in the proper patient, in a well-selected patient, menopause hormone therapy up to 5 years has absolutely no increased risk of any of the things that women worry about.
I see.
I sometimes say both for contraception as for hormone therapy, both are extremely safe. Some women are dangerous, and we have to identify the dangerous women and the obese, the ones who don't have that kind of physical activity, the heavy smokers, the ones with a high risk of venous thrombosis. The rest of them can do pretty well.
So in fact, it's a great point at which I just want to make that disclaimer that obviously everything that you're saying requires medical intervention. They should not be watching this show and going off and doing HRT on their own.
So let me support that disclaimer and say that whatever is there in your hands, if you are a healthy person living a healthy lifestyle, eating well, exercising well, you will always do most things in your life better.
Correct.
But there will be situations when it is not enough. That's when you've got to seek out the medical care that you are entitled to.
Sure.
Sometimes demand the medical care that you're entitled to. It is true that at some level, the medical profession has not been very good at prevention, has not been very good at doing things to just better the quality of life. We've been all trained in the mode of fixing things. We fix things, we treat things. How about not letting them happen in the first place? How about giving them a kind of an overall holistic, do this, do that, and do this? And that's probably the answer for a majority of people. But it has to be done under medical supervision by someone who is interested in this particular field.
Correct. So just to make sure that we don't miscommunicate, you are not saying I know for sure, and I just want to make sure that the audience understands this as well. I don't think the objective here is to say, listen to this podcast and then go out and do hormone replacement therapy or start taking aspirin or start taking metformin or any of those things. These are all medical interventions to be done only by medical experts.
Absolutely.
And I'm not one of them for sure.
Absolutely.
So if someone wants to try something like that, reach out to you and then chat with you.
Or to that friendly neighborhood
whoever
doctor,
exactly, the doctor is.
Yeah, but everyone has a primary care gynecologist who's looked after them.
Correct. No, wonderful. Okay. If I can move on then to menopause then. So then what's happening at menopause? What are those signs and symptoms? What can you do to sort of alleviate some of the challenges?
So once menopause happens, you start off life with a certain number of oocytes. You use them up all through life. And when you run out of them, you hit menopause. Now, once you've run out of oocytes, your estrogen levels crash.
Okay.
And you land up with what we call as hypoestrogenism. And most of the symptoms related to menopause are those of hypoestrogenism because it affects each and every part of a woman's body. So hot flushes being the most dramatic, they're time-bound. The first thing you do is smart stuff, dress smart, control your environment. We had this conversation earlier. This is the time when the bedroom has a temperature which the woman needs, but which the man dreads. So be it. When it comes to the other changes of menopause, like I said, the emotional, it's time to ask for help. It's time to have conversations with your family, with your husband, with your children, with the important people in your life, and ask for their support. And sometimes lay it down. Women, I believe that this comes to me from my patients.
Mm-hmm.
A lot of the book is experience from patients. And they will tell us how they've spent most of their life being so understanding and supportive. And when time comes in their 40s, they say, I think I've had enough. And now I'm going to stand up. And the people around her aren't used to the woman standing up and giving pushback. And that's when you need to tell them that this is what I'm going through, make them understand, ask for their help and support. And I think families, when they love you, will really give you that.
Absolutely.
Small strategies like when I tell my patients, they just fly off the handle and they spend the next 24 hours being miserable. I say, it's happening, walk away. Tell the family, don't follow me. I'll come back in 5 minutes and I'll fix the problem, but I'll be in a calmer state of mind when I do it.
Correct.
I won't lose it. So that's there. One of the issues which probably needs to be addressed is vaginal health. And after menopause, because you've got, I told you, dryness, vaginal atrophy, a lot of women, it starts maybe with painful sex, but there can be a lot of other things, more vaginal infections, more urinary tract infections.
Okay.
Incontinence becomes a problem. And the pelvic floor, which is probably the most neglected muscle in the human body because it's hidden, which plays such an important role because it keeps your insides against gravity, starts showing changes. Everything is laden with estrogen receptors. Estrogen levels fall, all these parts of your body start showing change. So that needs to be addressed. And there can be many different ways you do it. For me here, this is another place where using local estrogens is a game changer.
Okay.
Very safe, can be used for a very long time besides all the other stuff they do. Pelvic floor exercises are probably one of the most important things every woman in the world can do. And they should start from their 20s and 30s and they shouldn't have to wait till their 40s and 50s. Then there are other changes. And besides what we spoke about earlier, there is the changes in the skeletal system. Women put on bone like men till the age of 40 and then spend the rest of their life losing bone.
Correct.
And you build bone by your calcium metabolism, by your vitamin D, by your diet, but also by the kind of exercise you do. And I think that's something we need to get out there, that you have to do strength training, weight-bearing exercise to make your bones more dense and stronger. Because you're going to now lose bone, and women lose bone at a much higher rate than men in the first 4 or 5 years of menopause. Then the rate normalizes, goes the same as men, but by then women have lost a big part of their bone mass, and that's something we can address either in the form of prevention, identification, and sometimes even preventing further loss. Cardiovascular health. For women, they have protection from cardiovascular problems by estrogen. They lose it once they reach menopause. So better cardiovascular health. Their benefits of estrogen on the lipid profile suddenly goes. So you need to always eat better, do things better, and seek out medical help whenever required. Sexual health. I think that's the elephant in the room, which very often nobody wants to talk about.
Yeah.
And it's a conversation that women must have with their partners, with their doctors, because that definitely can be helped. Painful sex can be helped by making the vagina healthier, use of estrogens, use of lubricants, but more importantly today, we are also working on ways of improving libido.
Okay.
So menopause is definitely not the end of reproductive life. It's just a kind of, what should I say, a temporary pause. Things are going to change. You adapt to that change. You do your best to kind of make things as good as possible and then keep going the rest of your life in a much better state.
Wonderful. It was so empowering, actually, everything that you said. I will definitely move to talking about your book. But before I do that, I want to talk about a very interesting subject, which has, in some sense, nothing to do with your practice, but has to do with your persona. I first met you at 3 o'clock in the morning. And you know that you've kept people waiting till 3 o'clock in the morning. We were very happy to be waiting. But when I met you at 3 o'clock in the morning, you shone radiant. You were the beacon of calm and peace. And later, much later, I realized that you'd almost spent like 20 hours prior to meeting us, having managed all kinds of different crises. You were still. This is a term I like to sort of use a lot. I'm using it for myself. I'm trying to practice how I can be still. Stillness for me is this ability to be calm, unruffled, regardless what is happening in my life. And it's a practice I'm cultivating for myself, that life will be life. And whatever I can do to keep myself still, that's a great practice to inculcate. It's been 10 years, but 10 years ago, you were as still as anyone can get. Given the profession that you're in, where every moment, literally dealing with life and death, right? Of course, you're giving birth to life, and 99.99999% of the time, it is life. But it is also something that carries risk. How the hell do you manage to be so calm? I just that's something I want to learn.
So, I don't know. It's something that I've always been.
Okay.
And I've been really fortunate to be doing something that I totally love doing and I'm passionate about.
Okay.
So when I first read about that, the Japanese concept of ikigai.
Correct.
I said, that's my profession.
Yeah.
I love it. I think I'm good at it. I think it's something the world needs. And it's a profession. It keeps me going.
Correct.
So I'm really fortunate. I love every minute that I spend with my profession. I love every interaction I have with that patient. Once that woman and her husband are in the room, they're the center of my universe. I don't care who's waiting, how long they are waiting, what is waiting for me. I learned this term many years ago from my wife, who was in customer service. And she said, then there's customer satisfaction and there's customer delight.
Sure.
And I want that delight in their lives. And when there's delight in their lives, there's delight in mine. With obstetrics, there are dramatic situations.
Sure, of course.
And trust me, I will have this absolute inside you, there is all this turmoil. But if you want to keep going and if you want to keep everyone around you calm and doing what is best for your patient, you cannot let it out. And over the years, you get better at it. With my patients, I have infinite patience. I believe. So it's not difficult. I just do it. My kids sometimes tease me that dad's in a Zen space. And for me, it's really like that. I just do it.
So, sorry, if you don't mind, I really want to learn, and that's the only reason I'm pushing. So, let me give you an example. There's a very famous tennis player, I just don't want to take his name, who loved what he did. He was really good at what he did. But he was also theatrical, right? He would throw the racket, he would, throw things on the court, he would yell and scream. He loved the profession.
Yeah.
But he wasn't still.
Yeah. So for me, I love that term, stillness. So for me, I'm probably the tennis player who didn't show it.
Right.
Whose heart rate was 50.
Yeah.
And whose blood pressure was low. And he was very successful for a very, very long time. So here I'm in the operation theater and things are really not easy. I remember a pilot who was a patient's husband in the room when things were happening. He said, how could you be so calm?
Correct.
And I said, what happens when you're facing turbulence in your aircraft? He says, I don't show it.
Right.
And that's what you have to do. So you build this calm space around you. When you are practicing stillness, everyone around you practices stillness.
Right.
I know some operation theaters can be pretty dramatic. I know there are surgeons who are always throwing instruments around, shouting. Trust me, that's like a pressure cooker. Nobody's functioning at their best. But if I'm calm, I've got music playing, I'm chatting, we're having this light banter. At the same time, extremely focused on what you're doing.
Correct.
Because you don't know what's going to happen to that next patient that you're operating on. It starts off with personality, but practice probably makes it easier. It's not difficult at all.
You make it sound so easy. So I know when our son was born, there was Beethoven playing in the theater room. So I completely get what you're saying. But is this something you can teach? Like, forget teaching people about gynecology. Why can't you just teach them about being still? Because you're remarkable, truly remarkable. Like, given what you do, the way you're able to be still is remarkable.
I wish there's a lot of things that maybe I can teach my students, because a lot of us learn by example.
Right.
My example and role model in a way was my mother.
Okay.
My mother was a doctor. She was in government service. And, you don't expect government service doctors to be, but she was the most sensitive, caring doctor in the world. Her patients loved her. She was with BRC. And so for me, that was a great role model when I saw this person who was always there for a patient, who was always calm, who was always great. So that was my role model. But somewhere I agree with you, Ritesh, that we have to bring this into training and education.
Right.
The West is trying to do it. A lot of the medical education in the West is capturing not just the medical skills, but also the interpersonal relationships, communications and things. But they can only be taught to a certain extent.
Correct.
Your best chance of being good at this is having a teacher or a mentor who's good at it and learning from them. Because if you don't have someone like that, you learn the bad stuff.
Correct. No, because in my limited, I've just been, doing something in health for 10 years. I think without question, the most important thing I've learned is to be empathetic, because empathy wins the person over. There's instant trust. And then after that, anything you say and do will be well received, because the genuineness of what you're trying to do is evident.
Yes.
The kindness that you come with is evident. Yeah. After which actually you won the patient. Most people want to be treated well. Yeah. I don't know anyone who doesn't want to be treated well. And I think that's what you're remarkable at, like truly remarkable. I mean, if anyone has not experienced you in a one-on-one setting, they have to actually, and if there is a way for you to teach what you do, I think you should find a way to teach it, because it's truly.
I do get invited and lecture a lot. And we had the conversation of vaginal birth. One of the most frequently requested lectures I give today is optimizing vaginal birth in clinical practice.
Right.
Another area I'm very, very passionate about is safe abortions and women's rights and contraception. So wherever I'm communicating, I do try and convey. I mean, there's no secret to what I'm doing. Of a lot of the things we spoke about today, I want all doctors to give importance to communication. I want all doctors to be empathetic, to be patient, to be kind. And sometimes I think people don't know better. People always want to do well.
Yeah.
They just have never experienced how to do it.
Thank you for watching. Being connected to each other is easily one of the most powerful emotions a human being can feel. On that note, I have a very small request to make of you. Lots of you watch this channel, but not all of you subscribe to this channel. If you subscribe, you'll get notified of all the new episodes that we're going to be releasing very shortly. We've had some fascinating conversations with some amazing people who have so many powerful lessons to teach. So please do subscribe. If you subscribe to the channel, you will know about all the new episodes we're releasing. So please subscribe now. Let me turn to your book. That's the book that you've written with Mrs. Shonali Sabharwal. I've read it. I've read it twice now, actually. It's a wonderful book. I think it's a book that was much needed in the Indian context, at least. Because what you've done is not only talked about the various issues, you've talked about it in an Indian context, which I think is extremely valuable. Could you just walk me through it a little bit, help me understand what was the objective?
So, late one night, Shonali met me at my clinic. She's a very dear friend who was a patient, but also a friend. And she says, can we do a book together?
Sure.
I said, yes. I always said it was a moment of weakness because it took many years to write. But it was the most amazing experience. She'd gone to a publisher with this proposal. They said, go get a doctor. We suddenly found that we had two different voices. We had to bring them together, and we
Correct.
kept both our voices. She is an author who writes with her own personal stories, anecdotes, fun stories.
Correct.
She's very good with her nutrition and lifestyle work. I had to be extremely medically solid and evidence-based. We spent almost a year bringing two voices together.
Correct.
And then we started writing the book. It was a great experience. It is something that's done with a holistic perspective.
Right.
I have written as a doctor without a medical ego. And my joke with Shonali is this book is Ayurveda meeting modern medicine.
Right.
I am totally fine. If my patient is going to be helped by something, I'm open to it, even if it might not be my forte or my field of expertise. And what we've done with this book is we've tried to give the reader, and we are hoping men will read it as well, because I really believe that this is a time when you have to come forward and support that woman in your life who supported you unconditionally all this time. So the whole idea of this book was give women the information, give women the ideas. When it comes to the medical part, they will go to their doctors better prepared.
Correct.
To ask questions and to request help. Better than going to a site which is giving biased information. I have no problem with patients going on to Google and doing Google searches. I encourage it. But we do understand that they do not have the skill sets of analyzing what's out
Interpret,
there.
yeah.
So here's someone who understands it, has done it. Two people bring their own skill sets to a book, read it, make your points. It's amazing. I have patients coming to me today who've read the book, who come with a full scap sheet full of points and questions they want cleared. And that was the purpose of this book.
So absolutely. And so what I have done is actually I have a physical copy. I've also bought an electronic copy. What I do with the electronic copy is I start making notes. So I stopped reading fiction a long time back. I only read nonfiction now. And when I read, I learn. And what I learn, I actually write down and say, okay, here's what I learned. So one of the best markers of how much I liked a book is how many notes I took away. I must have taken away some 350 notes from your book. Somebody who reads a lot, I've read, I'd say, maybe 1,000 books on the medical sort of field itself. And yet I took away so much from your book. So if anyone's not read the book, here's the book. It's called Finding Your Balance. Please make sure that you get a copy of it. It's available on all major sort of bookstores. Obviously available on Amazon as well. Grab your copy. It's a wonderful book. Man or woman, it really doesn't matter. I think it's a book you must read. There's a lot to learn. At some point in time, you will have someone in your life whose life is being affected by some of the topics being discussed here. And so, if you're educated, I think your ability to find compatibility, to find harmony, and to find happiness within your family, I think will dramatically change. So make sure you get a copy. Make sure you buy one quickly and read it for sure. It's a wonderful book. I've read it twice. Like I said, I made lots and lots and lots of notes. A lot of it, which actually, frankly, we're incorporating into what we do, because there is so much to take away. There's so much to learn. There's so much to sort of implement.
For me, it was a learning because when we did this book, I have worked with Shonali on each and every part of what she's written.
Right.
And it was constant learning for me as well. The medical part I did and I could do. But when it came to the other part, the lifestyle, the understanding of diets, I think it's extremely important today that we cannot practice medicine as we always have done. We have to practice medicine with an open mind. We have to keep the person you're looking after at the center of the equation. And I just want that person to be well. And maybe for the wellness and for the well-being, we probably have to look at places other than conventional modern medicine.
That's so wonderful. I think with that note, we can kind of conclude this conversation. You are, clearly a different doctor. You are very skilled at what you do, but yet your willingness to look at things other than, just medicine itself is truly refreshing. I think that's why your patients get the outcomes they get. You take a holistic approach, which is patient-centric, and what else can you do? And if you can bring empathy and kindness to the table alongside, that's just, absolute win-win. So no, truly an honor. I think, like I've said, you are God for us. I don't know how else to describe it. My mom and dad, obviously, people I adore. But after that, you're someone I truly adore because you gave us the most important blessing in our lives, two wonderful children who we love very dearly. So thank you. Really, really appreciate you coming. Thank you for coming.
Thank you, Ritesh. Thank you so much.